Good morning and welcome to the Weekend Wellness Hour. I am very happy to have with me a special guest today, Dr. Michael Sumko. Dr. Sumko and I met probably about 4 years ago when I was a physical therapist working in a traditional physical therapy clinic. And I got the opportunity to watch him perform some surgeries. And so I was in the operating room with him and I got to see his good skills, techniques, and even the amazing rehab that people went through after having his surgeries. And so part of this program is bringing to you great healthcare professionals who really care about your progress, who really care about getting you to that next level, helping you heal to get you back into life. And so I'm very excited to have Dr. Sumko join us today. And he's going to be talking to us about hip and knee replacement surgeries, revisions, and the latest and greatest in the technology, and how that can actually help us get better faster, get us back on our feet. And so I want to share a warm welcome to Dr. Sumko. Thank you so much for joining us today.
Thank you, Amy, for having me. It's my pleasure, honestly. It's good to be here.
Wonderful. So why don't you share with us a little bit about your background? How did you even get into this field?
So my father was actually an orthopedic surgeon, and I grew up actually going on some house calls with him. Sometimes I'd be in the car and he would get a phone call. We lived in a smaller town, Brigham City, Utah, and I used to go with him to go and see patients, and I saw how much they appreciated it. And being in a small community, there were only two orthopedic surgeons, my dad and his partner. And I had many people all the time pull me aside and tell me how much they appreciated what my father had done for them or their family or their child. And so it kind of got me interested in wanting to be in the healthcare industry so that I could, help people. I got a good appreciation for just the gratefulness, and it made me feel good. And so I decided I wanted to go that route. And so I was always interested in going into healthcare, whether it was a doctor or a dentist. I wanted to be able to work with people.
That's wonderful. And then you played football as well. So was that also part of your desire to look into orthopedics, or was that just something you enjoyed?
Absolutely. I think my dream job would have been to become an orthopedic sports surgeon and go back and work with BYU. That's where I did my undergrad and played football. And I actually was injured my senior year and I had to have surgery by an orthopedic surgeon. Mm-hmm. And I was grateful for that, grateful that I was able to get some of my function back. And it led me towards wanting to do surgery. And I knew I wanted to eventually go to medical school at that point in time. And I wanted to do surgery so I could help restore function.
Okay, that's wonderful. Now, what kind of was your path in medical school? So why don't you tell us a little bit about that? Because I know some people have different paths when they go through medical school, then residency, and then their specialization.
You bet. So I think when you go to medical school, you're either medically minded and you like primary care, and you or other doctors where you're more or less working with people and their medicines, and you're not doing surgery, or you're surgical minded where you really like to work with your hands. You like to split the office up with the OR, and so that you have opportunities to work with your hands in a different environment. In medical school, I was out in Pennsylvania, and you do your first 2 years of medical school in the classroom. The next 2 years, the last 2 years of medical school, are doing rotations. And as I did rotations and I participated in the surgical rotations, I was really interested. I love the OR. I love that you got to work with a team, and it felt almost like I was still playing sports. And so it was a great transition to say, hey, I want to try and do challenging things and work in a team environment. And that goes even beyond the OR, obviously, to the office staff, to physical therapy, and surgery was interesting to me. So I decided I was going to do orthopedics because I loved structure and function. Okay. And I was in medical school. I went to a DO school, Doctor of Osteopathy, which for those who are on the Zoom call might not know the difference between an MD and a DO. MDs and DOs learn everything you need to know about medicine. And then the DOs have additional, I think it was like almost I think it was 7 or 8 hours extra a week, additional of classes where you're doing hands-on stuff. You're learning about how the body's a unit, how structure and function are related, and how you can help people in almost more holistic ways in addition to the medical skills that you learn. And so a very hands-on approach to treating the patient as a whole. And so I did. I wanted to be a surgeon. So after medical school, I got into a 5-year orthopedic residency program where I did orthopedics. You're a doctor at that point, but the next 5 years, you're learning to become a surgeon. And so for those 5 years, it's pretty grueling. And at the end of it, I decided to do an extra year of training in joint replacement, primary and revision joint replacement. And I chose that over the sports route and not going to be the sports doctor is because I really got to see what you could do for people who had worn out their joints, who were inactive. And I decided that I wanted to do joint replacements because I saw the immediate effects of surgery afterwards.
That's great. And as we know, the more we can keep people active, the more vital they are, the less comorbidities they have, the less they're, go downhill. So it is so important to keep people up on their feet and moving around. And that's wonderful. And now you studied with Dr. Tony Headley, right? For that additional training. Can you kind of dive into that? Because that's a slightly different approach. He has some advances in replacement surgeries. Is that correct?
Yeah. So Tony Headley, master of soft tissue preservation and trying to keep the anatomy as much as normal as possible. And fantastic fellowship director, fantastic fellowship and training. And some of the things that are different that I do that I would say there's not a lot of guys doing it. When I came to train with Headley, Dr. Headley 6 years ago, he had developed a new approach to hip replacements, which is called the direct superior approach. I was trained in residency, the anterior hip approach, the posterior, the lateral, mini posterior, and then I came out to fellowship and I learned the direct superior approach. And my patients just did so much better than even the anterior approach. People hear a lot about the anterior hip approach because the medical device industry spent millions and millions of dollars developing smaller implants that you could put in through an anterior approach. And the other thing that's popular with the anterior approach is you don't have to give hip precautions. And so coming out of residency, I thought I'm going to do anterior hip approach. Then I learned Dr. Headley's direct superior hip approach, which the patients recovered even more quickly and I don't have to give hip precautions. So it had all the things in one and I didn't have to use any specific medical device company. I could use any company. I could put in any size implant. And so naturally it was the best of the best for me and I saw the best results.
That's incredible. So when someone comes to you, let's kind of talk a little bit about, let's say someone has hip or knee pain, because those are the two joints that you specialize in, correct? Okay. So they come to you and they're having pain. What are the determining factors that lead you to say, okay, we need to go the surgical route?
Yeah, that's a fantastic question. I think the most important thing is a lot of people are afraid when they come in that I'm just going to say, hey, you need surgery. And that's not the case.
Yeah.
The most important thing I can do as a physician is listen to the patient, find out what their goals are, where they're at in their treatment of their pain, and try and help them to achieve what they're looking for. And so when they come in, the very first thing we do, obviously we get x-rays. We want to see the structure. We want to see how much bone space collapse there is in their joint. If there's any alignment issues or things going on. Some of the alignment issues can be corrected with bracing. So there's certain braces that we can put on that will help kind of, if someone's rubbing one side, we can help straighten it out. Anti-inflammatories people can take. Physical therapy, to get in and to kind of reset their structure that's been out of alignment for so long. And I know you do a fantastic job with that and helping people to calm down their nervous system when someone's had an injury and their muscles have been tight and tense for so long, they compensate for it. And in compensating, it throws off the entire function of how their anatomy is supposed to function. And so, you know, it's honestly, it's fun because it's like being a detective. You get to say, okay, we're coming in. What do you have? What's going on? How did you get here? What else? What have you done to this point? And what can we do to help you? And when people have exhausted, so for knees, for example, steroid shots, gel injections, anti-inflammatories, physical therapy, bracing, when they've exhausted all those things, then surgery becomes an option. And so, and we talk about that. There's obviously risks to any time you do a surgery, but yeah, I think it's getting to know the person or the patient as a whole and going from there.
Yeah, and I can imagine there is that fear factor. Now, there is people, you know, people typically have some type of diagnostic imaging, like X-ray or MRI, something like that. I get X-ray more for bony issues, but how accurate are those in terms of when you look at an X-ray that someone has, do you see more degeneration in the joint by the time they get to surgery? And is there a good correlation between that X-ray and their level of pain and whether they need surgery?
Yeah, that's interesting too. And everyone's a little different. Some people will come in and they'll be bone on bone and they say, Doc, I don't have a lot of pain. My leg is bent in, you know, it's bowed in and I'm losing range of motion, but I don't have a lot of pain. And then you'll have other people who have just a little spot of arthritis on the femur bone and a spot on the tibia. And they're we call them kissing lesions because they touch and they're an incredible amount of pain. And so sometimes it doesn't correlate. Sometimes there is more arthritis than what the X-rays show or what an MRI shows when you get in there.
Yeah, and it's hard. Like you said, you're a detective and you're kind of putting all these pieces together. So can you kind of go through some of these new advances in joint replacements?
Sure, you bet. So with my training with Dr. Headley, the biggest advances I think that get people up and going and moving the fastest. As you remember, you were able to observe some of the surgery. With a knee replacement, I do not cut the muscle. I move your entire quadriceps out of the muscle. And less than about 4% of people in the world do it that way.
Wow.
And people say, why is that? And that is because it does take a little extra training, but also takes about 10 minutes longer in the OR, which I know people go, what the heck, 10 minutes longer? But this muscle sparing technique puts you 6 weeks ahead in therapy from day one. And it's worth the 10 minutes to have the patients do that well. So the biggest advances is less invasive tissue sparing techniques. And so the direct superior approach for the hip and muscle sparing total knees, people are ahead of the curve by about 6 weeks. In addition to that, there are other things that have happened in advances. The plastic piece that goes in between the metal pieces of a hip or the metal pieces of a knee has become more compressed. The way that they've learned to manufacture it makes it so it lasts longer. So where knees and hips used to only last about 10 to 15 years, now they're lasting about 25 years.
That's
and
amazing.
So that's a really big advance, probably in the last 5 to 7 years. The materials are getting better that they're using. We know not to use metal on metal anymore. It creates metal ions and your body attacks the tissues in the joint. Ceramic on plastic is the standard bearing surfaces for a hip. So the components are getting better. And then they've also given us they've started to do some robotics. And robotics is also helpful in getting the correct alignment. Certain scans, there's patient specific instrumentation. There's a whole range. I could probably talk for about 45 minutes on it. So, but
no, this is good.
The techniques are better. The materials are better. They're giving you better devices in the surgery to help you do a better job. And so it's helping really improve recovery. I used to have a YouTube channel, This Ain't Your Grandma's Total Knee. And it's not, because things have changed and because of the approaches that we do.
That's great. And now, so with the knee replacement part of it, do you have that long scar that's usually like 5 or 6 inches that goes down the front of the knee? What's the difference on the scar? Because that's still big deal to a lot of people seeing that, Frankenstein scar down their leg.
It is. And so everybody heals differently. I'll start that. That's the disclaimer. Some people form keloids, some people's scars widen out. The way that I do it is I do a plastics closure. My PA, who I've taught him to help, we do a nice little plastic closure. No staples, so no Frankenstein.
Wow.
You don't come back to the office. You don't have to get staples out. This is all dissolvable sutures.
Okay.
The midline incision for the total knee does have to typically be about 12 centimeters.
Oh, okay. That's smaller.
About 12 centimeters. It's 4 to 6 inches usually. It depends on your body habitus too. And that's not what makes the surgery necessarily minimally invasive, the length of the scar on the outside. What makes the surgery minimally invasive is what happens underneath with the muscles and the tendons and the ligaments. And so in a knee replacement, yes, I still do have a midline incision. It will heal nicely if you heal greatly. If you're a good scar healer, then you should have a nice little line. But underneath is where, instead of the traditional approach where you go up and around the kneecap and do a medial parapatellar approach and split the quadriceps in half, I go up and then I go to the side, like a 90-degree angle.
Okay.
And don't touch any of the muscle. And then we move the entire quadriceps over.
That's incredible.
Can straight leg raise, go up and down stairs. You get up and walk an hour after surgery and you get on your way.
Is there any difference in the swelling afterwards because you've cut less muscle, or is it still pretty swollen?
The swelling can still happen, and but usually there's less pain and your range of motion is better.
That's great.
But yes, anytime you cut bony cuts, your bone tends to bleed a little bit. You will have tissue swelling, but yes, protecting the tissues, you can have less swelling traditionally than normal. And I have seen that since the last 5 years, implementing this muscle sparing subvascus is what it's called, muscle approach. To the knee, I have seen less swelling. So yes. That's
wonderful. And then how about the motion? So I know traditionally physical therapists were always really excited to get 105 degrees of flexion, 110. And if you got to 120 or 30, that's like a miracle. So what have you seen in terms of range of motion, getting that back?
That's a fantastic question. Yeah. And I always tell therapists the biggest predictor and patients, the biggest predictor of post-operative range of motion is pre-operative range of motion. Yeah. So some people will come in and they only have, they can only flex to 70 degrees and they've been that way for 15 years. Well, their tendons and ligaments are so tight, everything's tightened down. I can put in a knee that should give you up to about 130 degrees of motion, but they have to work through those tight ligaments still. It's a restructuring and refunction of the knee. And so that's where I love working with therapists, because therapists are the key. I can do a perfect surgery, but if someone doesn't have the contact every couple of days and somebody pushing them and working with them and teaching them how to move their knee correctly and rehab, then it won't be a success. Yeah. And so therapists play a huge role in having it. But yes, not cutting the quadriceps muscle, you do get your motion back a little easier and a little faster. And we shoot for, I always tell people too, functional range of motion is 95. If you have 95 degrees, you can get out of a chair, you can go up and down stairs, you can ride in the back of a car or an airplane. But we love to get over 110. If you're over 110, you're doing fantastic. You can kneel down, you can play golf, you can do pretty much anything you want to do.
That's awesome. Now, and since the technology's improved and now joint replacements are lasting around 25 years or up to 25 years, are you still recommending people that they hold off on more of the heavier weight-bearing stuff like jogging?
Yes, fantastic question. So all the orthopedic studies that show where this new plastic, right? It's only been around for 7 years, but they say it lasts 25. So how do they do that? Well, the way they do it is it's all cyclic motion. And so they say, okay, this person's going to cycle their knee. And so they have this little machine and it's doing cycles, and it's doing millions and millions of cycles. And they want to know when that plastic starts to wear out. And they say, hey, the average person walks X amount of millions of cycles their knee X amount of times in a year. And so it's all done on cyclic loading, not impact. And so the recommendations, yes, are not to jog. So I tell my patients, you can hike, you can do bicycling, you can do elliptical, you can swim. lots of things, but I tell them if you have to run to get out of the way of a car when you're crossing the street, go ahead and run. But it's just not recommended.
Yeah.
And people who do the impact stuff, they will wear out their plastic a little bit earlier.
Okay. Yeah. And I mean, that does make sense. Just, we kind of have to be aware of it. And I'm sure just getting any function back in terms of all those other activities makes someone extremely excited, even if they can't do something like jogging. There's plenty of other things they can do.
Yeah.
So I want to dive a little bit into the hip, the superior hip approach. So can you go into that a little bit? What's spared in that versus the traditional posterior lateral and then the newer anterior approach?
Yeah, you bet. So there's actually a pretty good study that's out. It was done by the Mayo Clinic, and they had a surgeon who did 1,000 direct anterior approaches, and another surgeon did 1,000 direct superior approaches, and found out that the direct superior approach, the approach I do, is actually even less muscle sparing. The approach itself it's hidden underneath. If you want to wear a bikini, it's hidden underneath it.
Okay.
It's about the same thing, 10 to 12 centimeters, depending upon, how your body habitus. If you have more skin and more adipose tissue, the incision has to be a little bigger.
Right.
But I go down through the skin. I find the gluteus maximus raphi. So your large glute muscle has striations, and there's splits, and you find a split in the striation. So you're not cutting any muscle. You find the split, you go down, you open up that split, and you come down to the posterior part of the hip. There are a couple muscles back there, your little external rotators. I do take a piriformis tendon and I take that up, but at the end of the case, I also put that down and I tie it into the bone right to where it goes.
Okay.
And so that is the tendon that I move out of the way, and then everything else, the capsule's there, and I go right through the capsule, expose the femoral head, and then I'm able to dislocate your hip and cut off the femoral head and neck, and I can then expose the cup or the acetabulum, and I take a cheese grater and I basically make a nice new bowl for my titanium cup that I press in there, and then I get a stem down the femur, and then we put a ball on and we relocate it and we come back through. So there's really not a lot of tissue at all. The only tendon that I remove, like I said, the piriformis tendon, lifting that up, but I do put it back at the end of the case. And the posterior approaches, they used to come down. They didn't necessarily find the raphi or, and split the gluteus maximus. They would just kind of find an area where their anatomy, they come down, they go through the raphi, they go through the IT band, which that's the other thing I avoid in the direct superior, IT band, so that people don't get lateral trochanteric bursitis in my approach, which is awesome.
That is awesome.
And so they'll go down through the IT band, they open that up, and then they go and they take off 4 different external rotators. They just... You come down, you take off the rotators, you peel them back, and you put them back at the end of the case. But you do basically take off all of your rotators except for one, the quadratus muscle. And then the rest of it's kind of the same. You don't get as good a capsular repair in a posterior approach. You have to put all those external rotator muscles back up. It's the more you can leave your anatomy in place, the better.
Yeah. And then with the superior approach, I mean, I know with posterior lateral, there's tons of restrictions, but superior, you said there's no restrictions.
No restrictions.
You can bend over.
Yeah, I do. The nice thing about the other advances is they have x-rays that are pretty awesome now. Nowadays, they can bring in the OR, so I can get an intraoperative x-ray and I can make sure that the cup position and the stem and the leg length are right on. And if you can match the natural anatomy, you don't have to give hip precautions. They'll have a stable hip.
Okay.
So, I try and do it as accurate as possible with measurements and imaging, and I don't have to give hip precautions.
That's great. Now, when you're putting it in there and finding the size of the joint and measuring it, are you looking at the opposite leg length and trying to match it with that? Or are you, because I know as people shift into this chronic pain condition, their position changes, so it could become shorter or just a different length. So do you match it with the opposite leg? Hopefully the opposite leg is still okay.
Yeah, absolutely. Great question. So in my x-rays I take in the office, I have a templating digital software. And so I'm able to draw on there and figure out, where the legs and how to match them up. And there is anatomy that the lesser tuberosity, and the greater tuberosity, there's anatomy that we match and we try and do it. And exactly, I never want to shorten someone's operative leg if I haven't operated on the other side. You always want to make it as long, or if you're going to err, you're going to err a little bit longer. And then when you go back and do the other side, you can make the other side match it. When you shorten someone's leg, they lose the abductors, they lose their muscle strength, which is also a stabilizer to keep their hip in and really help with their gait, as you know. And so you never want to shorten someone's leg. You never want to decrease the offset of their leg. And so real important, yes, take the intraoperative x-rays, use all your tools, make your measurements, do your preoperative templating so you have in mind what you're going to try and do and the sizes you're going to use. And it can be a very, very successful surgery. In fact, hip replacement's probably the most successful orthopedic surgery ever because it's a ball and socket replacement, and you can really help people get rid of their pain and be mobile again.
Yeah, and it's great. It's not like a knee that swells up that is so limited in motion. And usually hips, I mean, they have some swelling, but in my experience, I haven't seen it be so restrictive that they can't do their, simple things like walking, getting out of a chair. It's usually really successful. That's incredible. And then I have a question though about, do you still use any glue? I know that was a thing that used to have cement versus no cement. And
Correct.
what is the latest and greatest on that?
Yeah. So Europe, if you're a Europe trained surgeon, you like to cement stuff. They like cement. Okay. United States, we like to press fit things. And so press fit means that there's bony ingrowth, porous coating on the implants. And say I want to put in a size 7 stem, well, I'll broach to a size that's just maybe 1 under. And so that when I put it in, it presses in against the bone and compacts, and then it'll stick. And then the bone grows onto the prosthesis and it becomes part of your body. And that's still the standard here in the United States. So we like to press fit as much. All the hips, we press fit them. If they have really bad bone and you can't get a good stick, then you can cement. Honestly, in all since I've been out for the last 6 years, I haven't cemented a hip. I've press fit them all. Now knees, the standard of the knee is to cement the knee. The company I use, medical device company I use, has a press fit option for the knee. So if they have really good bone, these younger patients, and we're seeing a lot of arthritis earlier on in people's lives because of activity, but 50-year-old people, even up to 50 to 75, if you're an active person, I have my marathon runners that come and they wear their knees out. They come in, they have hard bone. They have been compressing that bone for so long. Well, the bone is good. And so I can actually put in a press fit ingrowth component and not have to worry about a cement mantle or the cement. The cement is one more thing in between the prosthesis and the bone that can fail. And so if you don't have to cement, great. But if you do have to cement in the knee, that's kind of the standard for people who don't have very good bone.
That's amazing. That's good. So now, unfortunately, there are times where people have revisions. A friend of mine actually just had a knee revision yesterday. Unfortunately, she didn't know you. And I just found out about this, and she had seen someone a long time ago. I guess it failed. She's had pain. And so she did have a revision yesterday. So can you walk us through what are the indications of a revision? What do you see on scans? How does that happen? That's
fantastic. So there's a couple different reasons to do a revision in a hip or a knee. One reason is an infection. If you have infection, you have to do a revision. You have to get the infection out. The bacteria sticks on the components. You have to take the components out. You have to do an antibiotic spacer. And then once you get rid of the infection, you're doing your revision, putting in your second time, or the third surgery in that case, knee. When someone comes in with a painful primary joint that they've had replaced, I look at it and I say, are you having pain or are you having instability? And these are reasons for revision. If you're having pain, why are you having pain? Is it because the components are put in a little bit wrong? Well, then they probably need to be revised. Are you having pain because you're having, the components are oversized? Maybe they're just a little too big and they're rubbing on the tendons and the ligaments, or they're rotated just a little bit, so is pain, is pain an issue? And then instability is an issue. Sometimes people will put in knees that are too tight or too loose. And if
Okay.
they're too loose, they get a lot of movement, and the movement creates pressure on the capsule, and that creates swelling and pain.
Yeah.
And so sometimes it's going in, and it's all it is a matter of, if the components are put in well the first time, is putting that piece of plastic like a shim, like making that plastic bigger so that they have more stability. And so it's really pain, instability, or infection that lead to revision. And once again, that's the best part about being a detective,
Mhm.
is trying to figure out. So you do a revision for the right reason.
Yeah. Yeah. So when someone does have a revision, so if we're taking away the infection, we have to remove everything. If it's something related to instability, or it wasn't positioned correctly, or the size was incorrect, do you take everything out, or do you just replace parts of it if possible?
That's a great question. So you like to remove as little as possible. Every time that I have to take a component off of bone, I'm going to lose bone.
Yeah.
And the more and more times you're taking the component off or revising it, the more and more bone you lose. With that comes bigger stems that you have to put down the femur or the tibia, longer stems. Sometimes people have stem pain after that.
Mhm.
And if you lose too much bone, you get these salvage type revision components, and they're not comfortable, and they can fail.
Yeah.
So you do as little as possible. Less is more in a revision, but you also need to take care of what needs to be taken care of.
Yeah.
And if it's a malplaced component, you don't want to duck your head in the sand and go, we're just going to put a bigger piece of plastic in. No, the pain's happening, or your kneecap is maybe tracking lateral because there's too much rotation in the femoral component. You have to correct that. You have to take off the component and correct it. So really, if you're going to do a revision, you want to go to a surgeon who's going to take a look at the x-rays, but listen to the problems and then evaluate the knee, put all three together, and make sure that he's going to do a revision for the right reason.
That's good to hear. I remember when I was in one of my rotations when I was in grad school, and I was at Hahnemann Hospital, and I actually saw a full femur replacement.
Yeah.
It was a hip replacement that had gone bad, and I guess it had been revised, and there was wires that were going around the bone, and the whole thing crumbled. And so when they thought it was going to be just a third hip revision, when they got in there, the whole femur bone just crumbled, and they had to go all the way to the knee. And it was shocking. I didn't even know it was possible at that time, but they had no choice. And I remember there were some issues because I don't think they expected it to be that complicated. And so I don't know if they had all the parts ready for it. Because I imagine that's a whole serious difference to get a whole replacement bone to go in there.
Yeah. So so that is a major, that's almost like in tumor pathology, people will get tumors and they lose a massive section of their femur. And so they get a proximal femur replacement, or, to do the entire femur, you probably remember they had to splay out the leg completely.
Yeah.
And it's,
it's,
that I've actually only been in one surgery. So I'm impressed that you've seen that before too. It's not very often where they do that.
Yeah, not for the faint of heart to watch. I struggled through that one watching because it was just not expected, and it's sad because I mean our body is so resilient and it wants to heal, and it's amazing how much we can feed it to help it heal. But then there are times where if things are just off, and I believe that person was having an infection in the previous, and that's kind of why everything disintegrated. So it's sad to see in that sense. So when you do revisions, does the minimally invasive approach just kind of go out the window because you're kind of going in there and you're trying to make everything right again?
Yeah, that's a great question. So yeah, you never want to compromise your surgery by trying to do a less invasive approach. If you need to see more, you extend it. So yes, I still try and do the least amount possible in my exposure as long as I'm able to complete the operation. If I'm struggling, if you're in there and you're just pulling and twisting, you're pulling too much because your incision isn't great, that's really going to beat up the tissues. The person's going to get a lot of swelling, it's going to be sore. So there is I think that's the art of surgery, and that's probably where a lot of surgeons differ is, do you respect the tissues? Do you take the time to, not just slash and dash and open things up? Do you take the time to get good exposure? Do you protect the tissues. And that's why I love Dr. Headley. He was great. And in my residency, I had fantastic surgeons too, during my 5-year training program, who really taught me to respect the tissues. And there's certain instruments that we have that are less, they're not just clamping down and biting on your tissue while you're pulling them out of the way. There's an art to it. There really is an art to it. And until you're either a resident or you've been around a lot of different surgeons and you see how they work, you realize that there is an art to surgery, and there's a reason why some outcomes are better than others. And that has to do with optimization too of patients. I don't know if we're going to talk about that or not, but
yeah. Actually, that would be a great topic to cover, is kind of how to best get a person back on their feet. So please, share.
Yeah. So optimization, and that's what I appreciate what you do and what you're doing now, trying to help people, to avoid surgery or if possible, but get their body in the best shape possible. Get their immune system in the best shape possible. If you're diabetic, make sure that your hemoglobin A1C is below 7 if you're going to get an operation. Now, there are surgeons who will operate on you if you have a higher hemoglobin A1C, and it's too bad because it puts you at a risk of not healing your incision. If you're a smoker, you're going to be at an increased risk of at least 2 to 4 times the risk of having an infection and not healing. And so I make sure I stopped operating on smokers about 4 years ago. After I was out my first year, I had a couple infections, and they were on smokers who had gone back and were smoking a pack a day, even though I tried to make them quit. And so now I pushed it out. So if you come to me and you're a smoker, don't worry. I'm not going to say I won't ever operate on you, but I will help you to quit smoking in that preoperative period, and at least for 3 months afterwards. So 3 months before, 3 months afterwards, you really got one shot to get it done right the first time, where you're going to have the least amount of, it's going to affect your life and your work and everything else the least, if you get it done the first time and recover quickly. So smoking, diabetes, and then obesity is another thing. It's 6 times our body weight through our hip and knee joints. And so if people, and I love the therapists, and I love how you take that whole approach to health and wellness. If you lose 10 pounds, that's 60 pounds less pressure per step. And I try and tell my obese patients, and that's the thing, most of America is obese. No one has a BMI of 25 or less. And for those of you that are listening that don't know what BMI is, it's body mass index. And body mass index is a calculation of height and weight. And so the problem is, if your BMI is high, it's just because you're not tall enough, so you can blame it on your parents. But or lose weight. So
one of the two.
Yeah, one of the two. But arthritis is like a pebble in your shoe, and I tell my patients this too. Arthritis is like a pebble in my shoe. If I'm sitting down and I have a pebble in my shoe, it doesn't hurt. As soon as I stand up 6 times my body weight through that shoe, all of a sudden I put my weight down on that pebble starts to hurt. And at some point, whether I pick my leg off the ground, take 100% of my weight off, I relieve the pressure, and the arthritis doesn't hurt. And so it's the same thing with people with arthritis. Sometimes they'll gain, and a lot of this is, people have had this happen in COVID. I had no knee pain, and then COVID came. I didn't get COVID. I was like, well, you can't blame it on COVID, but I gained 20 pounds. Okay. So now you're putting 120 pounds more pressure through your joint. So what little arthritis you may have had before, now all of a sudden, like that pebble is starting to hurt. And so getting people to a BMI of 35 or less is optimizing the patient to have a good surgical outcome. And when you do that, and this is my last little spiel I'll give, but I think it's important because I think education is the key. And when people are educated, they'll make the changes. They'll be compliant. But the risks when your BMI is over 30, and the Academy of Orthopedics did a study, when your BMI is over 30, you have a greater risk of infection, which is life-changing. That's at least 2 more surgeries. It'll change your life. You don't want that. You have a greater risk of blood clots, right? You don't want blood clots because blood clots can turn into pulmonary embolism and kill you. You have a greater risk that the components will loosen. It's just the pressure through the joints. And you can put in a nice component, but if there's too much pressure, it can loosen. You have a greater risk that you'll go back for revision surgery. So when you're overweight or obese, you're going to most likely have another surgery. Patient satisfaction scores, interestingly enough, when your BMI is over 30, patient satisfaction scores go down.
That's interesting.
People just aren't as happy with their joints. And that's the worst thing you could do, I think, is go through a big surgery, a recovery, and come out of it and go, I'm just not happy with my joint replacement.
Yeah.
And they actually say that 1 in 5 people are not happy with a joint replacement, that's crazy to me, because that's not my practice at all. And I think it's because I really do strive to optimize the patients with their smoking, diabetes, obesity. I do a less invasive technique. I treat the patient. We work with what the patient wants, their goals. And I would say maybe, in 5 or 6 years, honestly, I have probably less than 5 people in my whole practice who come back and they say, I wouldn't get my other side done.
Yeah, that's pretty good. Do you also, one of the things too with optimization, I always talk to people about food. And
Yes.
do you recommend, and have you seen that if people eat more plant-based, or if they eat meat versus dairy, and I know everyone's genetics is different, but have you seen any difference? I don't even know if you've taken this data, someone's diet versus their outcome.
Yeah, well, nutrition, I don't have the exact data on that, but nutrition is key.
Yeah.
I do feel that more meats are inflammatory. There are certain foods that are more inflammatory. My medical device rep, who I just love and look up to, he's been great. He's been with me since my fellowship.
Yeah.
He was a big meat eater. He had multiple knee surgeries before because of playing college football as well, and issues. And he turned to vegan, and all of his inflammation went away, and he doesn't have knee pain anymore. So he swears by it. So, but yes, certain foods, there are certain things that we take in our nutrition that can cause inflammation. So avoiding those, I do believe is important. And then the other thing is protein, and whether you get it through soybeans or, or chicken or fish or whatever, protein is real important in the healing process. Your blood protein, your albumin needs to be a certain level in order to heal afterwards. So malnourished people with poor nutrition, diabetics who are uncontrolled, those are the people who it does affect your outcome in healing, and that will ultimately affect your results.
Yeah, and I'm curious on a quick turn on that one too, is also caffeine. I'm curious your thoughts on caffeine, because I know caffeine affects your ability to sleep, which we heal a lot during our sleep. Have you seen, do you recommend that people kind of cut down on the caffeine a little bit, drink more water?
That's good. I think water is the key in weight loss.
Yeah.
Drink your body weight in ounces, or whatever.
Yeah.
And if you can really do that, it'll be better for your kidneys and everything. Caffeine to me is a drug. So if I'm tired, if I drink a soda pop, I'll be straight awake and wired for the next 8 hours, easy.
Yeah.
But yes, I think anything that is habit forming or a stimulant, you do have to be careful. But I would always recommend water over any drink. I think, for people who say I need to have flavor, do water with a little Crystal Light or something.
Yeah.
But yes, water is much, much better than caffeine. I don't have any studies that I can quote or tell you off the top of my head, but the other thing caffeine does too is it's a vasoconstrictor. It's a stimulant, and when you're healing, you want to be able to have good blood flow.
Yeah.
And I don't know what the dose of caffeine would have to be in order to compromise that good blood flow, but nicotine, caffeine, these things do affect the healing process.
Yeah, they affect us. So if you're going to make that huge decision to go have a joint replacement, why not, like you said, maximize your body's health when you're going into it. We don't want to start in it compromised and just hurt our recovery. So I completely understand.
Absolutely. I think that's the key to success. Optimize. Find a surgeon who has a high standard, who wants to make sure that your interests and you're protected, and you'll have the best outcomes. Unfortunately, I just think there's too many. There's guys in my med school class. That's the funny thing, right? The guy who, what do you call the medical student who graduates last in his class? You call him doctor. And you don't know that.
It's true. You're right.
He's a doctor, but he graduated last in his class. Is that the guy that you want treating you,
Yeah.
Surgery is a very competitive residency. So there's a lot of surgeons. Some guys have great grades but not great hands or great skills. You know, I hear all the time, you know, that people come to me for a second opinion. That's my surgeon just didn't listen to me. He was jerk. You know, he was very jerky. You know, and there's people that will operate on anybody for whatever reason. Sometimes it's, you know, and it's hard, and medicine is hard, and private practice has become harder and harder. And business has become a lot slower in coronavirus. And so people have loosened their standards, unfortunately. And so more surgeries being done on probably patients who should be optimized. And that's leading to worse outcomes and infections and complications. And you really want surgery, you shouldn't take it light. And people, if you haven't been around surgery, you don't know enough about surgery, you need to realize that there's not any surgery that can be performed that can't make you worse. And
very true.
And so you do really need to not take it lightly, and the whole body approach is super, super important.
And I really appreciate that. And that's one of the reasons why I wanted to bring you on, because I remember how much you really took time with people. And even your patients, when I used to see them, they would tell me that. And that's vital. They were shocked that orthopedic surgeon, and now chief of orthopedics at the hospital, Tempe St. Luke's, congratulations. You take the time to work with people and listen to them. And that's so critical. We can't just be robots when we're working on someone and saying, okay, I'm going to just look at your knee and not consider anything else. And I really appreciate your approach. And I hope people do reach out to you, because you have their best interests in heart, and it comes through too. So thank you.
Well, thanks, Amy. I appreciate it.
Yeah.
That's honestly what makes my job fun and enjoyable, is you know, really being able to connect with people and hopefully leave them in a better place than when they came into my office. And that's what makes me go to work. That's what makes me tick. And if I have patients who, you know, aren't happy or, you know, aren't pleased with their results, I take it personally. And it's hard on me, but you know, fortunately, knock on wood, we've got a great team, great staff, and I think we got great techniques and great, you know, we've really honed in to try and optimize every part of the surgical process, and including the patient's wellness. And I think people have a great outcome, and so it's very, very gratifying.
So how can people reach you if they want to come see you? Do you have some way that we can share so people can reach you?
You bet. And maybe you can post it later somehow.
I can.
I do have a Facebook page. It's my name, Dr. Michael Sumko, hip and knee specialist.
Okay.
So SUMKO, Dr. Michael Sumko, hip and knee specialist. That's my Facebook page. Or if they want to call right now, I am hospital employed. I work for Stewart Healthcare.
Okay.
Here in Tempe and Phoenix. I have offices at Tempe and Phoenix.
Okay.
And if you want a number for that,
what's that number?
That's 602-553-3113.
We're testing you here.
You are 602-553-3113.
Okay, good. And I can put that in the notes.
They could always call and make an appointment. And I don't have anyone who runs my Facebook page. It's just kind of me. So I post videos. I am busy, but I do check, and people will message me, and I could always pass on more information, how to get a hold. And so.
Yeah, well, we really appreciate your time. Thank you so much. Is there any last little piece of advice you want to give to anyone?
I would say, one last question, and I did want to talk about, people always ask, you know, when is it time to get my knee or hip replaced? And I tell them, when you're losing function, when you stop doing the things you love, or all you do is plan your day around your joint, because we should be able to do that with surgery if you can't do it with physical therapy and with you, Amy. If your followers aren't done everything you've said, and they just can't get it, and it's time for surgery, those are the things. Because hopefully surgery should improve function, decrease pain, and allow you to live your life and get back to doing the things you love. You know, play with your grandkids and go for walks and function. So
that's wonderful. Well, thank you again for joining us. I really appreciate your time. I know everyone listening is appreciating it too. Some good feedback already. So thank you so much for your time.
Well, anytime, Amy. Thanks for having me. I appreciate it.
Wonderful. And thank you all for joining us today for the Weekend Wellness Hour show. We will see you again next week. Have a great rest of your weekend. Take care, guys. Bye.